Hello Med-Surg students. I'm going to explain to you the indications for a chest tube. Now Med-Surg students are usually intimidated by chest tubes, but you shouldn't be. I'm going to give you a simple explanation of why they're inserted, okay? So normally everybody has negative pressure in their thorax, okay? And around our lung we have the pleural. Okay, so we have the visceral pleural and we have the parietal pleural. And in between the two pleura is a potential space or the pleural space. Normally it has a little bit of fluid to make our pleural slide over each other very easily when we're breathing. But if we get an infection in this area or there's some kind of inflammation, we might get that pleural friction. It sounds like two pieces of leather rubbing together. So anyways, the reason somebody may need a pleural chest tube, okay, is because when you have air or fluid or pus in the pleural space and it's taking up more space, okay, the pressure in the chest turns positive. So a physician is going to insert a chest tube to make the pressure negative again. We want to restore normal negative pressure in the chest. That's just a simple way to explain it, okay? The goal of putting in a chest tube is always going to be to maximize ventilation, okay, and improve the gas exchange. Okay, so those are two very important reasons we would put something in. So when the chest tube is put up high, that's to drain air, and that should make sense because air rises, right? So a high chest tube is to drain air, whereas a lower chest tube is to drain fluid, okay? Now, when I used to work in the PACU taking care of patients post-lobectomy, they had both an upper one and a lower one, and they were connected to a Y tube and then to a closed drainage system. Or sometimes some providers would want them on separate closed drainage systems. So it's nothing to be intimidated about. If you know what the care is that is involved with chest tubes, you'll be a safe nurse, okay? So let's talk about assessment of chest tubes. What is your role, okay? So remember the order of assessment, and if you don't remember it, just use this phrase: I palpate perfectly, amen. So on inspection, you're going to come in, and if you're in the ICU, it's probably every 2 hours. If they've moved to the floor, the Med-Surg floor is probably going to be every 4 hours. You're going to expect the dressing. You want it to be dry and inclusive, okay? Usually you change that daily. So you're going to look at the site when you change it daily. You're going to note the sutures if there are sutures. You also look for signs of infection. Now, another thing you need to look for when you're changing the dressing is eyelets, okay? So what that is when the physician puts in a chest tube, the chest tube is like a long tube, right? But it's got eyelets in it, okay? And these eyelets help drain the air and the fluid. Now, the physician puts it in to the chest, okay? So the eyelets need to be inside the pleural space. So if you see eyelets, you have a problem, you need to assess your patient and call the provider, okay? And obviously if your patient is in distress, you're gonna call a rapid. Okay, in terms of palpation, when you come on shift, when you change your dressing or you're looking at it, you're gonna feel around the chest tube site. What you're looking for is something called subcutaneous emphysema, okay? Also described as crepitus. So you might see either of those two terms in the literature. It feels like very fine popping under your skin, okay? This means there's some air escaping around the tube. So if it's a new finding, that's significant. Assess your patient and let the provider know, okay? That's important. Now, with percussion, I have seen quite a few NCLEX questions about percussion with people with chest tubes or people with pneumothorax, especially. They're going to have hyperresonance to percussion. And then people with, fluid like a hemothorax or a pleural effusion, it's going to be dull. So percussion will be dull. You'll get dullness, okay? Auscultation, again, you're going to have diminished breath sounds if somebody has a pneumothorax. You won't hear the breath sounds on that side. And if somebody has like a hemothorax or a pleural effusion, you're not going to be able to hear breath sounds in that area. So hopefully over time, you're going to see an improvement. Now, one thing I didn't mention, there's two types of chest tubes. There's a pleural tube, which I drew here, but there's also the mediastinal tubes. Remember, I talked about them in the CABG lecture. And it could be like after open heart surgery. And one of your main responsibilities with any kind of chest tube, especially post-op, you want to make sure it is draining properly, especially mediastinal tubes, because if they stop draining, that can cause a cardiac tamponade, okay? So review the signs and symptoms of cardiac tamponade, because you definitely don't want that to happen. So another thing, having a chest tube in can be quite painful, especially when they're breathing, which they have to do continuously, right? So make sure you're medicating your patients enough so that they're going to engage in pulmonary toilet. And what I mean by that is they're going to turn, cough, and deep breathe. They're going to want to get up and ambulate. They're going to want to use their incentive spirometer, because if they're in a lot of pain, they're not going to want to do that. And then they're going to get acidotic. So you want to make sure that they are doing the deep breathing they need to do. Also, you also want to make sure that these tubes are always patent. Make sure your patient is not lying on it. I mentioned in another video that if these get occluded, you may see the titling in the water seal chamber stop fluctuating. So look for that, okay? But you want to make sure this is always, these are always patent and they can drain freely. Now, no matter if it's draining air or fluid, when this gets connected to the closed drainage system, you always want it below the level of the chest, okay? And make sure there's no dependent loops in that tubing. That is a big pet peeve of mine, because then the fluid is not going to drain properly, and you don't want them to develop clots, definitely, okay? The other thing is you only clamp a chest tube in rare circumstances. For example, less than 1 minute. Say you have to change the closed drainage system. You can clamp it for a minute while you're doing that exchange, but we usually never clamp a chest tube, okay? So that about does it for chest tubes.